This podcast is brought to you by Intra-Naturals, a supplement brand whose core mission is to improve the health of 100 million people by 2025. People's Pharmacy listeners get 25% off their first order using the code PEOPLES25 at intranaturals.com. That's code PEOPLES25 for 25% off at intranaturals.com.
Women are often more health conscious than men, except when it comes to their heart health. Why do women ignore heart risks? This is the People's Pharmacy with Terry and Joe Graydon.
The American Heart Association says that women may overlook symptoms of a heart attack, such as shortness of breath, nausea or vomiting, and back or jaw pain, as well as shoulder and arm pain. It can take women considerably longer than men to realize they might be having a heart attack and get emergency attention.
Two of the country's leading female cardiologists join us today to explain what women should do to protect their heart health.
Coming up on the People's Pharmacy, a wake-up call for women on keeping their hearts healthy.
First, this news.
In the People's Pharmacy health headlines, eggs and other dietary sources of cholesterol do not appear to raise the risk of heart disease or atherosclerosis in carotid arteries. Researchers in Finland tracked healthy middle-aged men for more than 2 decades. At the start of the study, the men filled out detailed dietary surveys to identify their eating behavior. 1/3 of the participants were at high risk for both heart disease and dementia. That's because they carried the ApoE4 gene that predisposes people to both conditions. When the data from Kuopio, Finland was analyzed, the scientists could find no relationship between cholesterol intake or egg consumption and heart attacks or strokes. Perhaps it's time to lift restrictions on cholesterol-containing foods and recognize that the early prohibitions were based more on beliefs than on data.
Americans have been warned to avoid saturated fat for at least as long as they've been told to avoid eggs and cholesterol-containing foods. Although the most recent dietary guidelines for Americans have eased restrictions on eggs, there's still a clear warning to cut back on foods containing saturated fat. But a new study from the Netherlands calls that pillar of nutritional advice into question. Over 35,000 Dutch citizens participated in the European Prospective Investigation into Cancer and Nutrition. A food frequency questionnaire provided insight into the amount and kinds of saturated fat people were consuming. The subjects were followed for 12 years. The authors concluded that people who consumed high amounts of saturated fat were not at a greater risk for coronary artery disease. In fact, those who ate more foods containing saturated fatty acids were actually less likely to develop clogged coronary arteries. The investigators point out that there are a number of different kinds of saturated fats, and some appear to be protective rather than harmful. This follows a meta-analysis of 16 epidemiological studies that also did not find a link between saturated fat intake and heart disease.
A long-term study has found that people who love chocolate and eat it more frequently do better on tests of cognitive function. The Maine Syracuse longitudinal study recruited people starting in 1975. In 2001 to 2006, 968 volunteers went through cognitive tests. Analysis of the data revealed that those who ate chocolate more than once a week had significantly higher scores on tests of visual spatial memory, organization, scanning and tracking, and the MMSE, that's Mini Mental Status Exam. The study did not differentiate between milk chocolate and dark chocolate, although prior research suggests that high flavanol dark chocolate can benefit brain function.
Researchers report counterintuitive results from a trial on treating hemorrhagic or bleeding stroke. The Phase 3 trial tested the use of TPA, a clot-dissolving compound, in patients with bleeding into the ventricles of the brain. These ventricles normally contain cerebrospinal fluid. Getting TPA directly into the ventricles in a timely manner reduced death rates by 10% and reduced the disability of survivors. What makes this surprising is that clinicians have carefully avoided giving TPA or other clot busters to people suffering hemorrhagic stroke for fear of making the bleeding worse. Now that protocol may need to be reevaluated. In this study, the TPA was delivered to the brain ventricles through catheters that had to be placed very carefully so the drug would reach the right part of the brain.
Exercise testing can reveal how well blood is flowing to the heart. Overall, men are more likely to have reduced blood flow, called ischemia. But women with anxiety disorders, including generalized anxiety as well as panic disorder, are more prone to myocardial ischemia. When this blood flow to the heart is restricted, people may experience chest pain, neck or jaw pain, or shortness of breath. Ischemia does not always cause symptoms, however. In the study, 2,342 patients went through exercise stress testing and a thorough assessment of mood and anxiety disorders. While anxiety had no effect on men's heart function, women with anxiety were more likely to have ischemia. The symptoms of a heart attack in women could be mistaken for an anxiety attack and lead to a diagnostic delay or failure, according to the researchers. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. When it comes to health, women are generally much more proactive than men. They're concerned about breast cancer and osteoporosis and take steps to prevent these devastating conditions by seeing their healthcare professionals regularly. But heart disease remains the number one killer of women. When it comes to heart health, too many women may be overlooking their risks.
To help us understand what women should be doing to protect themselves from heart disease, we turn to Dr. Rita Redberg. She's professor of medicine at the University of California, San Francisco, and director of the UCSF Women's Cardiovascular Center. She's the editor of the journal JAMA Internal Medicine.
Welcome to the People's Pharmacy, Dr. Redberg.
Thank you. I'm glad to be here.
Well, it's nice to have you back on the People's Pharmacy. Dr. Redberg, I guess one of the things that's very confusing to us is this sense that women somehow are protected from heart disease, that this is a problem of middle-aged and older men. Myth?
Well, it's true that on average, women are 10 years older than men when they get heart disease. And I think that's a lot of where it came from. So where we start seeing heart disease in significant numbers in men in their 50s, we don't see it in women until their 60s, and the incidence doesn't really become equal for both sexes until really the seventh decade, and so until you're like 75 or so. And so women are older when they get heart disease, but they get it as frequently as men do.
So women and men both get heart disease, but women are older.
That's correct. And of course, women still live a few more years than men. So it means women are continuing then to get heart disease then.
Now, we've heard that heart disease in men is declining at a pretty good rate. I mean, we have made some real progress, but not so much in women. Why not?
Absolutely, we have made progress, particularly in men. The changes are less for women, we think, for a number of reasons, but part of it could be less of a recognition of the importance of heart disease in women, and that heart disease is still largely a preventable disease. While we may not prevent it forever, we can certainly delay its onset for many years by a lot of healthy lifestyle factors.
Let's talk about that, because I think that when we're talking about preventing heart disease, we're really talking about a long-term project. Men who want to prevent heart disease need to start before they're diagnosed with heart disease. I'm assuming the same thing is true of women.
Absolutely. I always tell people it's never too late to start, but the earlier you start, the more advantage you have.
What's the biggest impact that we can do, the one thing we can do that will have the biggest impact on reducing our risk of heart disease?
Well, for many, it's always been smoking is the number one preventable cause of heart disease. Obesity is now nipping on the heels of smoking as the preventable cause of heart disease.
And we keep hearing that we're facing an epidemic of obesity in this country. Is it affecting women about as much as men or more so?
Well, it's actually affecting women more than men, and that could be another one of the reasons for why women aren't doing as well in prevention is that the rates of obesity and overweight are higher in women than they are in men. About 2/3 of American women are overweight or obese.
Could you say that again, please?
2/3 of American women are overweight or obese.
That's unbelievable.
It is, and that wasn't true even 10 years ago.
Yikes.
So we are not going in the right direction.
Now, there's this idea that younger women are somehow protected, that it's only when a woman gets into her 60s or even later into her 70s that she's at risk. And I'm wondering if we have any sense of why. Why is it that women seem to have that 10-year advantage over men? We heard earlier, yes, it's hormones. It's estrogen. I think there was even a study where they gave men estrogen in the hopes that it would protect them, but it didn't. So what's the story?
Right. You're absolutely right. We did think for many years it was estrogen that was protecting women, and that was why a lot of the guidelines used to say that women should take estrogen for heart disease prevention. I mean, as you know, they no longer say that because luckily, finally, randomized clinical trials were done of very high quality and showed that there was no benefit for women in preventing heart disease with estrogen. And you're right, there was a coronary drug project that used estrogen for men, and it turned out it was not only not helpful, but harmful. It was causing a lot of blood clots and bad things to happen. So we no longer think that it's estrogen that's protective in women, but we don't know why women are 10 years older with the onset of heart disease. We really don't know why women are living longer, although it could be related to that lower rate because heart disease is still the leading cause of death in men and women. You know, we know a lot of things like women have healthier blood vessels for more years. They have more favorable lipid profiles, and particularly the good cholesterol that sort of protects you is higher in women. And even though it goes down after the menopause, it remains higher. And those things were all related to estrogen, which is why it was so attractive to think that estrogen was protecting women, but it's just not as simple as that.
And I'm wondering if obesity kind of messes all of that up.
Oh, absolutely. You know, the best way to prevent heart disease is lifestyle. It's a good, heart-healthy diet and regular physical activity. People who are obese are usually not eating a very healthy diet in general, or they're eating too much of it at any rate. And obesity makes it harder to exercise.
Yes, it does.
And so
kind of a vicious cycle there.
Exactly. And then you don't also feel as well, of course, when you're not exercising and you're obese, because a lot of other bad things happen, like your joints hurt, you have back pain, so a lot of things that then prevent people from getting out. So there's definitely a relationship between obesity and all of the heart disease risk factors.
Now, you mentioned diet. There is probably nothing more controversial in American health today than what is a heart-healthy diet. For years, it was low-fat, and we had our margarine that was supposed to be, without cholesterol and so much better than butter, and now we've done a complete U-turn on the margarine-butter thing. But fat is still somewhat controversial. You've got, at your end of the country, Dr. Dean Ornish, who is still an advocate of low fat and a vegetarian approach. But we also have people who say, no, fat's not the culprit. In fact, go ahead and enjoy fat. It's probably good for you, and especially if it's the right kind of fat. So can you give us some sense of where you stand in this controversy?
Sure. And I think you're right. There has been a lot of sort of conflicting information, which I think is confusing to Americans. But I think the good news is that it's pretty clear now, or pretty clear at least to me, from all of the studies and all of the data, that a Mediterranean-style diet, so a diet that really emphasizes fruits and vegetables, whole grains, whole foods. It can include fats, including some butter, but olive oil, not trans fats, which you basically stay away from, is clearly a healthy diet. And that diet has been shown to prevent heart attacks and to prevent onset of heart disease. I actually think someone else in my part of the country, Michael Pollan, said it best when he said, eat food, not too much, mostly plants.
And he said, eat real food, which is...
Absolutely. Shop the perimeters of the grocery store, so not inside, don't buy things that have more than 5 ingredients on the label. Don't buy foods your grandmother wouldn't recognize, but really eating whole food. So eating real fruit instead of fruit juice or fruit bars.
One of the things that we frequently hear in a description of the Mediterranean diet is not meat, but fish and legumes, beans and peas and lentils, that sort of thing.
And I think that's correct. I think it's okay to eat meat, but I wouldn't do it every day. Once a week is okay, and it's okay not to eat meat too, but certainly having a diet that is concentrated in legumes and fish as sources of protein and eggs is a much healthier diet.
Eggs? We get to eat eggs?
Yes, you get to eat eggs. Eggs are a really good source of protein, and they have a lot of things that are good for you. The other thing I just have to say, being from California where we're in a terrible drought, is that the amount of water that goes into 1 ounce of beef is estimated to be the same as a family of 4 needs in an entire day. So beef is a very intensive water consumption, and another reason, environmentally speaking, that we need to cut our beef intake.
Something to think about. We also hear that beef is high in cholesterol, and of course eggs are also high in cholesterol. We hear that cholesterol is a problem for heart disease. Do we need to worry about the cholesterol we eat?
No, cholesterol is really, I think, been overdone as a risk factor for heart disease. So cholesterol is really just one part of risk factors for heart disease, and in particular, the cholesterol that you eat is a really small part of heart disease risk. And so if you're eating cholesterol in the context of that healthy diet, it has very little to do with it has something to do, but not all to do with your blood cholesterol, which is a lot more determined by your genes and genetic factors. But the other thing is that there are a lot of people that have high cholesterols that will never get heart disease. It is a very small part of your heart disease risk. We have kind of overvamped it as a risk factor.
You're listening to cardiologist Rita Redberg, professor of medicine at the University of California, San Francisco. She directs the UCSF Women's Cardiovascular Center, and she edits the important journal, JAMA Internal Medicine.
And Terry, the committee that's responsible for the Dietary Guidelines for Americans 2015 through 2020, they agree with Dr. Redberg. They've confirmed that it's okay to eat eggs, and dietary cholesterol, not that big a deal.
Exactly right, although they still urge us to watch our saturated fat.
After the break, we'll compare cholesterol to other risk factors for heart disease.
What about the psychological aspects of cardiovascular health?
How do smoking and birth control affect women's heart health?
Should women take aspirin to prevent heart attacks?
We'll find out about treating blood pressure to benefit the heart, and we'll also consider whether women should be cutting back on salt. How good is the evidence supporting statin use for women?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you value the health information you get when you listen to The People's Pharmacy, consider subscribing to our email newsletter. You'll get the latest health news and information on upcoming podcasts delivered to your inbox twice a week. Look for the link at peoplespharmacy.com. Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Intra-Naturals Nutritional Supplements. Information on how they're redefining nutrition can be found at intranaturals.com.
And by Redix Industries, makers of utterly smooth creams and lotions that deeply moisturize to make dry skin feel soft and smooth. The number is 800-345-7339. The website is uttercream.com.
If you would like to order a CD of this show, you can call 800-732-2334. This is show number 1026. That number again, 800-732-2334. Or you can find it online at peoplespharmacy.com.
Today on the People's Pharmacy, the topic is women's health. In particular, we're exploring how women can reduce the risk of heart disease, their number one killer.
We're talking with Dr. Rita Redberg, editor of JAMA Internal Medicine. She's professor of medicine at UCSF, where she directs the Women's Cardiovascular Center.
Dr. Redberg, for years we've been told that, if it wasn't cholesterol, it was LDL cholesterol. And if it wasn't LDL cholesterol, it was some other fraction, very low density cholesterol. And it was the size of the particles, and it was how much HDL you had. And for the most part, people didn't look at other risk factors, like hostility for example, are you an angry person? How much exercise? It oftentimes was not computed. It was, let's just get your blood levels and, here's a prescription. So could you give us a little sense of some of the other risk factors for heart disease that should also be considered besides the blood lipids?
Sure. I like to think of them in two groups, modifiable and not modifiable, and concentrate on what's modifiable. But just to say, age and sex and family history, which are not modifiable, are important risk factors. But there's nothing we can do about those. But the modifiable risk factors, we've talked about. Smoking is still the number one preventable cause of heart disease. And then the other ones are really related to what we've been talking about, diet and physical activity. So physical inactivity is a risk factor. High blood pressure is a risk factor. Diabetes is a risk factor. High cholesterol is a risk factor. All of those being related to physical activity and diet.
What about the psychological aspects, that issue of hostility? We've heard that there's an association, but I've never seen a study that showed lowering your anger factor would actually reduce your risk of heart disease.
Or how would you do that even? And, of course, there's stress.
Right. And stress and hostility are clearly linked to heart disease. Stress, hostility, and even depression or psychosocial isolation. I mean, we know that people that have those will do worse and are more likely to get heart disease. But the more important thing is, how can we reduce those as risk factors for heart disease? And what has mostly been shown, it's very hard to control the stress in your life, but how people cope with that stress has been shown to be able to lower rates of heart disease. So if you have stress but are able to cope with it in a positive way, exercise is always one good way to cope with stress, but the other things are really making contact. So being in some kind of supportive relationship, either with a friend, a spouse, a partner, other family member, or groups. We know those people who are able to talk and sort of vent their hostility, their anger, their stress are going to do better than people that are very isolated and keep everything to themselves and inside. And so it's very hard to control how much stress there is in their life. We're all going to be subject to things that are stressful. So the important thing is to be able to develop positive and healthy coping mechanisms.
Now, a lot of younger women smoke and also take birth control pills. Mm-hmm. What's the risk in that situation?
Certainly smoking increases your risk of heart problems. Birth control increases your risk of embolic events, forming blood clots. But of course, most women taking birth control are quite young, so although they're absolute risk, so it's still 1 in 10,000. But say a woman who's on the pill might be 3 in 10,000. So it's still low, but it's higher than a woman who's not on the pill.
So we're talking about the difference between absolute risk, relative risk, and if the baseline risk is really low, like 1 in 10,000, mm-hmm. then even a pretty big jump, tripling of the risk, doesn't lead to a really high risk.
Exactly. It still is low. But of course, we try not to put women who are smokers on birth control pill because then now you've increased 2 risk factors.
They should look for other forms of contraception.
Yes, or stop smoking would be better.
That would be better.
Now,
that would be better.
Now, a lot of people think there's a magic bullet, and we'll talk about statins in a moment. But first, aspirin. Mm-hmm. A lot of men are taking aspirin preventively because they've been told and they've seen commercials that suggest that aspirin will prevent the big one. What about women? And is there a role for aspirin as a preventive for women, and when do the risks outweigh the benefits?
Well, again, our thinking is evolving on aspirin, and it's, I would say, been another particularly confusing area for women because we have changed the recommendations a lot in the last 20 years. I think currently the best data suggests that women, certainly before the age of 65, should not be taking aspirin for prevention of heart disease or stroke. Then after age 65, particularly women who have other risk factors, could get a benefit from taking between 1 aspirin a week to an aspirin every day and just a baby aspirin, so 81 milligrams, because that still gives you the benefit on platelets, making your platelets less sticky, so less likely to form blood clots, and has less bleeding risk. And so aspirin, we say usually with a meal, so you have a full stomach and it's more protected from bleeding risk. And the data really suggests you could take it every day or even every other day or once a week. But again, it's not for all women, and it's only women over 65 or older with risk factors.
Now, you mentioned that high blood pressure is a risk factor, and of course, when we talk about aspirin, separate from talking about heart disease, we say, well, if you have high blood pressure, you should stay away from aspirin because it increases your risk for a bleeding stroke. So how do we reconcile this differential advice here?
But what aspirin does reduce is your risk for the other kind of stroke, yes, which is actually more common than a bleeding stroke, but a stroke that comes from a blood clot going to your one of the blood vessels in your brain.
So I guess what we need to do is control the high blood pressure.
Mm-hmm. Yes,
well,
that's right.
Speaking of high blood pressure, it is a major risk factor, but it's been a moving target. And so there was a time when physicians didn't get too excited about hypertension until people's blood pressure was maybe 140, 150 systolic. And then there was this idea that 120 over 80 was normal, and that's what everybody should strive for. Even the 85-year-old woman who was probably at relatively low risk at that point in her life. Taking 2, 3, or sometimes even a half dozen different pills to get blood pressure under control could lead to all kinds of side effects, including dizziness, which itself can be a pretty serious risk factor because it can lead to a fall. So as a cardiologist, how do you sort through those benefit-risk ratios when it comes to treating women, in particular, older women, who have a blood pressure in the 130, 140 range systolic and maybe 80 to 90 diastolic?
Right. So again, our thinking is changing and has changed in the most recent set of guidelines on hypertension. And just as you say, it's really important to consider risks and benefits of treatment. And also, it's important to realize that it is true that people that have lower blood pressures have lower risk. But that's talking about people who have those pressures naturally, that they're lower, and they're frequently lower because those are the people that are following the heart-healthy diet that we talked about, and they're exercising regularly. It's not true that we have seen that same kind of risk reduction in people that have lower blood pressures because we have given them a lot of medicines to get there. And it is probably, just as you mentioned, there are a lot of risks to medications, and you can't sort of replicate the benefits of a healthy lifestyle in a pill, in which there aren't magic pills. We can lower blood pressure, and we can certainly get benefit from it. But getting a blood pressure down to what we used to think was a healthier level with pills has as much harm or more harm than good. And so we've now changed the blood pressure guidelines so that when we're treating, getting a blood pressure to even the 150 over 100 range has as much benefit and not as much of the harms, because blood pressure changes all the time. And so if we are treating so someone's blood pressure never gets above 150 over 100, the likelihood is there are a lot of times during the day when their blood pressure is much lower. And then there are the risks, as you mentioned, of dizziness and falls. And what we have seen is that particularly older people and older women, they have much higher falling risks when they're on multiple blood pressure medications. And falling is not a good thing for older women because it leads to hip fractures and other things that immobilize you and often lead to a very downward spiral in terms of quality of life.
One last question about blood pressure, and here again, I apologize. I think it's controversial, and we certainly have been hearing a lot pro and con about salt. We're told, don't eat salt. You really need to reduce the amount of salt in your diet because that'll keep your blood pressure under control.
And the CDC and, if I'm not mistaken, the American Heart Association aim for 1,500 milligrams a day or less.
Now, we have met a few elderly women who have been told to reduce their salt intake, and they've cut it to about 1,500 milligrams, which is really hard to do. They're very conscientious. Is that good for them?
So again, you're right. It's another area of controversy, and the IOM weighed in on this
Institute of Medicine.
The Institute of Medicine, yes, and suggested that we don't need to advise people to be as drastic in their salt reduction. And again, if you follow the kind of diet that we've talked about, where you're not eating a lot of foods that come in boxes and cans, you're probably not getting a lot of salt. But you also have to recognize, it's very hard to know exactly how much salt you're eating, just like it's hard to know, what % fat you're eating in your diet. And that's why I think it's really more useful to talk about what foods you should be eating and what foods you really should avoid or eat very little. And so certainly you should be enjoying the food you eat. And if you want to add a little salt when you're, cooking your vegetables, I think that's fine. And you're right, we have relaxed the dietary restrictions on salt.
Dr. Redberg, the last time we spoke with you, there was a huge controversy underway because there were new guidelines for heart disease and statin drugs, and there were a lot of different factions, if we can use that term, people who basically, they didn't say we should put statins in the water supply, but if you looked at the risk factor calculator, it seemed to suggest that just about everyone over the age of 65 should be on a statin. Anyone with high blood pressure should be on a statin, even if it was well controlled. And of course, anyone with diabetes should be on a statin. And you told us that the old recommendations where you were supposed to aim for a particular level of LDL cholesterol, and that had been changing. Originally it was maybe 135, and then it dropped down to 100, and then for some people it was under 70, that there was no good evidence to support that. The controversy hasn't completely gone away, but it's kind of died down. Can you give us some insight on the risk calculator, the cholesterol issues, and in particular the role of statins? Because there are still a lot of people who think just about everybody should be on a statin.
Well, and since we're specifically talking about women's heart disease, how good is the evidence that statins are going to reduce heart disease in women?
So my thinking on that hasn't changed in the 2 years or so since we talked last about the cholesterol guidelines. You're right that it's certainly not making the front page of the news anymore, but the last set of guidelines are still the current ones, and the arguments and concerns are still there, and I think will likely be addressed in the next set of guidelines. But the problems were with those guidelines that they used a new risk calculator that didn't seem to work when it was validated in other populations. It lowered the level of risk for very unclear reasons. So it now said that people at a 7.5% level of risk, which basically meant all men over 70, should now be talking about statins with their doctor. And it also took away the LDL targets, as you mentioned, which really upset a lot of doctors who were very used to using LDL targets. So I think that we're not talking about it as much, but a lot of people still are not using the current guidelines for a lot of the reasons and concerns. As we said, my own read, and I've read very carefully all of the data, I do not recommend statins for primary prevention, not in women certainly, because the data is very weak, and really it's not very good for most men either for primary prevention. So for healthy people who don't
prevention
have... Yeah, there are a lot of people who are very confused about this primary versus secondary. So please do give us an insight.
So primary prevention means that you're healthy and you don't have heart disease, but you want to prevent getting heart disease. And I think that if you want to prevent heart disease, and I think we all do, that healthy lifestyle is the way to go, and statins have little or no benefit on top of that, and on top of that, have a lot of risks.
So we frequently hear from women who say, well, I have an HDL of 85, but my LDL is around 120, and my total cholesterol is over 200. And and I feel fine, and I have no risk factors, and I had no history in my family, but my doctor wants me on Crestor.
So those women are low risk for heart disease, particularly assuming they're active and they're not smoking. And what I can say certainly is that statins aren't going to lower their risk. So I don't recommend statins.
What should they say to their doctor? Because there are doctors who are really adamant, oh, your LDL is still 135.
Maybe they need to shop for a new doctor.
Yeah. I mean, I think it's important to sort of focus on what the evidence is. There isn't any evidence that lowering LDL in women is going to reduce their risk of heart disease. You know, it's a problem because that is what the guidelines say or said, and unfortunately those guidelines were not evidence-based and didn't really consider the risks and benefits.
Again, speaking of statins, what are the most common side effects, and what are the side effects that people should alert their physician to, that, you know, this drug is not working well for me?
Well, the most common side effects are muscle aches and pains, diabetes, stomach upset, and memory loss, or feeling like you're in a fog. But again, if there's any new symptom you've noticed after you've been started on statins or any other medicine, it's good to talk to your doctor, because there are other side effects that could be associated.
Dr. Rita Redberg, thank you so much for talking with us on the People's Pharmacy today.
Thank you. It was my pleasure.
You've been listening to Dr. Rita Redberg. She's professor of medicine at the University of California, San Francisco, and director of the UCSF Women's Cardiovascular Center. She's editor of the journal JAMA Internal Medicine.
After the break, we'll talk with Dr. Viola Vaccarino about why women are more likely to die after a heart attack than men are.
What factors put younger women at risk for a heart attack?
Stress, depression, and anxiety may all play a bigger role in women's heart health than was previously recognized.
Dr. Vaccarino will discuss her research on how emotional stress affects cardiovascular risk.
We've heard that anger kills, but most of the research was done on men. Are angry women also at risk?
You're listening to The People's Pharmacy with Joe and Terry Graydon. If you're enjoying this People's Pharmacy podcast, why not head over to our website where you'll find a wealth of information on medications, conditions, home remedies, and ways to keep yourself healthy. You'll find it all at peoplespharmacy.com. Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by Redix Industries, makers of utterly smooth foot cream with shea butter, helping dry, cracked feet feel soft and smooth. The number's 800-345-7339. The website is uttercream.com.
And by Intra Naturals Nutritional Supplements. Information on how they're redefining nutrition can be found at intranaturals.com.
To order a CD of today's show or any People's Pharmacy broadcast, you can call 800-732-2334. Today's show is 1026. That number again, 800-732-2334, online at peoplespharmacy.com.
Today, we're talking about what women should do to keep their hearts healthy. Women often fare worse than men after a heart attack.
To help us understand why, we turn to Dr. Viola Vaccarino. She's the Wilton Looney Chair of Cardiovascular Research at Emory University. She's professor and chair of the Department of Epidemiology in the Rollins School of Public Health.
Welcome to the People's Pharmacy, Dr. Viola Vaccarino.
Thank you.
Dr. Vaccarino, I think a lot of people are surprised, perhaps even shocked, to learn that women are more likely to die after a heart attack than men. Is that really true? And if so, why?
Well, what we have found is that women, yes, they are more likely to die than men after a heart attack, but this is particularly so for women who have their heart disease prematurely. I mean women who have heart disease when they are relatively still young, in their 50s, 40s, even 60s. So for some reason, when women get heart disease early on in their lives, they are a group that has basically a higher risk of complications, mortality, and adverse outcomes after their heart attack. Older women instead do not appear to differ from men that much. But young women have this distinct pattern of higher risk compared to men of the same age.
Now, when you say that younger women are more likely to die when they have a heart attack, I think a lot of our listeners are going, younger women don't have heart attacks. I mean, women in their 40s and 50s? Nah, that's really, really rare. It's men who sometimes have heart attacks in their 40s or 50s, and yet it does happen. Do we have any idea why?
Well, first of all, women, even at that young age, do get heart attacks. So it's not true that women do not get heart attacks early on at that age, and only men get disease at that early age. It is true that women are less likely to get heart disease early on in their lives, and men are slightly more likely than women to get heart disease in their middle age. But still, for example, in the United States, there are about maybe 10,000 cases of heart attacks in women less than 50 every year. So it's not like there's something unheard of. It does happen. And it is important to remember that these women who end up having heart disease early on represent a group that has higher risk than the rest. And we don't understand exactly why yet, because it's not related to the severity of their disease. They don't have more plaques, for example, than men do of the same age. Actually, if anything, they tend to have less coronary obstruction when they present with heart disease. They tend to have better left ventricular function, meaning that their heart actually functions better. But, they tend to have more diabetes, more obesity, so they have slightly more risk factors. But one distinct feature that we find is that these women have a higher burden of psychosocial risk factors, meaning they have more depression, they report more stress in their lives, more financial adversities. And we think that these burden of psychological and social conditions may actually have an impact on their outcomes in this particular group.
Well, Dr. Vaccarino, we know that in general women report more depression than men. Is that what you're seeing, or are you saying these women in particular are vulnerable because they perhaps didn't get as much education, they don't have good jobs, maybe they live with partners who are not treating them right? Is that the situation?
Yeah, all those factors may play a role in this population. We find very large rates of depression actually in this group. For example, in our studies among women less than 50, about 50% of them have a clinical diagnosis of major depression, meaning that they meet all the criteria for a psychiatric diagnosis of major depression requiring treatment, although many of them are not taking medications for depression. And they show all these other factors that in part you mentioned. They tend to be generally poorer. They report a lot of stress in their lives. They report issues even early on like early life stress in terms of being, during childhood have had adversities and maltreatment and things like that, which we know that are long-term risk factors for cardiovascular disease.
My understanding is this is an area that you have been investigating. Can you tell us a little bit about your research?
Yes, so we are really interested in trying to understand how stress and emotions affect cardiovascular risk. And in our research, we have found that, in fact, women may be particularly vulnerable about this adverse effects of stress and emotions on cardiovascular function and heart disease risk, and particularly the young women. So we had this observation that young women have worse outcomes if they get heart disease. And then we had these other observations that psychological and social factors may actually have a higher impact on cardiovascular disease risk as well as cardiovascular outcomes, mortality after the disease is already manifest. And so we have started looking into this issue more carefully. And we have conducted studies looking at how stressful challenge, a stressful stimulus can actually affect cardiac function and comparing women to men. So I would also like to add that one of the reasons why this field of stress and heart disease has been a little bit lagging behind other research looking at biological risk factors for heart disease is that stress and emotions are very variable in the population. People define them different ways. There are different types, different exposures, and so it has been, in general, difficult to pin out what's really going on. And so one way to go around this is to actually study this in a laboratory setting. So what we do in some of these studies we are conducting now is to create a mental stress situation where we provide a scenario to the patient about an emotional situation and ask them to provide a speech in front of a small audience addressing this issue. And so this is a very stressful challenge for many people to kind of come up and talk about an emotional situation in front of a small audience of people they don't know, who wear white coats, have kind of an intimidating outlook and intimidating atmosphere. And so by doing this, we monitor their responses in terms of heart rate, blood pressure, of course, the function of their vessels, but also we take pictures of their heart before and after we do this to see how their heart responds to this emotional challenge. And what we found is that women, particularly young women, less than 50, show much more abnormalities in their blood flow to the heart, meaning that in medical terms we call it ischemia. It's basically a lack of perfusion, a lack of blood flow to the heart that makes the heart basically function worse because of the lack of perfusion. And this is something that is being usually diagnosed in heart disease patients using an exercise stress test, for example, and then doctors take pictures to see whether the heart is okay, whether there are abnormal situation in terms of blood flow. So we do a similar paradigm, but instead of a physical stress, we use a mental stress. And so using this protocol, we have found clearly that young women show a higher vulnerability to this lack of blood flow to the heart, which is a sign of heart disease.
Well, it sounds like you have really selected a beautiful test to put people under psychological stress. Public speaking is something that a lot of people are very scared of. What are the implications of your findings?
So the next step is really to find, two main things that we would like to achieve in the future. One is to come up with a method like a mental stress testing technique that could be feasible to deliver in a clinical situation. What we are doing now is a study. So, we have all set up for a study, but it may not be exactly transportable to a clinic, for example, in a busy clinic where there's not very much time, a lot of things going on. And so that will be very important to find a way where maybe a simplified procedure could be created, could be set up, that it's actually feasible to be implemented in a clinical setting. And second, it would be very important to show whether there are specific treatments or interventions that can be useful to ameliorate these effects of the stress on the heart, particularly for women. And so far, we don't know what may be the best way to treat this. We know that, for example, stress relaxation techniques such as meditation, breathing exercises, even just regular physical activity, physical exercise, are helpful in decreasing blood pressure, helping with cardiovascular risk factors. We really don't know yet whether they are effective in this particular population. So that would be an important next step for us.
Now, many years ago, Dr. Vaccarino, a physician researcher at Duke University, Dr. Redford Williams, really started drilling pretty deeply into the issue of anger. And, in fact, wrote a book, I believe it was called Anger Kills. And before him, there was a lot of interest in the type A personality. But most of that work was devoted towards men. And there was this sense of the man who is hard driving and who had a short temper and who probably was under a lot of stress at work. And women were pretty much ignored. Yeah. The idea that anger could be dangerous for a woman, well, we don't think of women as getting angry. But is that a mistake?
Well, men and women are different, and psychosocial risk factors may be a little bit different in men and women. So for women, for example, depression is much more prevalent than an angry temperament. Issues like, as I mentioned before, early life exposures in terms of emotional abuse, physical abuse, sexual abuse, issues related to relationship stressors, in the family environment. So those are all dimensions that are much more common among women, and also financial adversity, as I mentioned before. So these components are much more prevalent among women. And another important factor for women is the burden of caregiving. So women, particularly those who are young, often take care of children, of parents, of spouses, and at the same time maybe they work full time. So this burden of responsibilities that women may have in that particular time in their lives, which may actually add up to a lot of stress.
Dr. Vaccarino, are there any red flags that women should be watching for, or that we should be watching for in our sisters and mothers and daughters, women that we know and love?
Well, depression is definitely a hallmark. In many cases, severe stress manifests as depressed mood among women. So that's definitely something that should be watched for. And, difficulty in sleeping is a sign that something is not right. So these are all kind of signs that there is stress in women's life and they need to do something about it.
Dr. Vaccarino, for the women who are listening and for their health professionals, what is the take-home message, and what can people do if they are feeling under stress or perhaps depressed? What would perhaps reduce their risk of heart disease if they're under a lot of pressure?
So we really don't have absolute answers on what is the best strategy to reduce stress in order to reduce heart disease risk among women or among men. But the best strategy that we know of at this point is to be able to take some time for themselves every day And I know that this is very difficult, particularly talking about this particular group of women who are very busy and overcommitted, and they have a lot of responsibilities. The group that actually may be experiencing higher stress levels. But this is really important. Take some time for yourself. If you can, go to the gym at least 2 or 3 times per week if you can. Or if you cannot do that, take a long walk, at least 20 minutes a day. Try to find ways to relax and think about yourself every day. So that would be the number one suggestion that I have for them. And obviously, in other situations when really depression becomes very severe and stress seems to be uncontrollable, in those situations, seeking psychological counseling should be the step to take.
Dr. Viola Vaccarino, thank you so much for talking with us on the People's Pharmacy today.
You're very welcome. Thank you.
You've been listening to Dr. Viola Vaccarino. She's the Wilton Looney Chair of Cardiovascular Research at Emory University. She's professor and chair of the Department of Epidemiology in the Rollins School of Public Health. Dr. Vaccarino served on the American Heart Association committee that recently issued a scientific statement on acute myocardial infarction in women.
Earlier, we spoke with Dr. Rita Redberg. She's professor of medicine at the University of California, San Francisco, and director of the UCSF Women's Cardiovascular Center. She's editor of the journal JAMA Internal Medicine.
Lynn Siegel produced today's show. Al Wodarski is the engineer. Dave Grayton edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is made possible in part by Red X Industries, makers of Utterly Smooth Extra Care 20 cream with 20% urea for extra skin protection. The number, 800-345-7339. The website, uttercream.com.
And by Intranatural's nutritional supplements. Information on how they're redefining nutrition can be found at intranaturals.com.
If you would like to order a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1026. That number again, 800-732-2334. Online at peoplespharmacy.com.
And when you visit our site, you can check out information on prescription drugs, herbal medicines, and home remedies. Share your own experience and your thoughts on today's show.
At the website, you can also sign up for our free online newsletter or the free podcast of the show. Never miss another People's Pharmacy program and share it with a friend. It's all there at peoplespharmacy.com.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening, and please join us again next week when we talk with Dr. Dale Bredesen about how to prevent or even reverse Alzheimer's disease.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.